Okay, welcome everyone. Thank you for joining us from Dublin to our online audience. To those in the room, you're very welcome here at the European and African HPB Association meeting and to our lunchtime symposium. I'm very excited to introduce our two speakers, but before I do, you may have noticed that I'm not Professor John Devar. My name is Catherine Gilbert and I work at Baxter, and I will be moderating this symposium. I look after the medical side of things in the UK, Ireland and the Nordics for advanced surgery. Unfortunately, Professor Devar couldn't be with us. He had some issues coming over from South Africa. So we have a large number of online participants joining us from around the world today. We had over 240 people expected to join us from surgeons around the globe. So we will have questions at the end, and hopefully from people within the room, but also from our online audience. I will ask that we save our questions because we will need to use a microphone for that, so everyone online gets the benefit of the questions and the answers. I hope you've all had lunch. If not, lunch is still running when the symposium finishes, so you will not go hungry. For those of you online, please enter your questions via the chat, and we will have what I hope to be an interesting discussion at the end of the two presentations. So let's begin. I would like to introduce our two speakers. We have Professor Harald Schrem, who is working as a general and HPB surgeon at the University Hospital in Chemnitz, Germany. He's very welcome today. And Professor Keith Roberts, a liver transplant, HPB and pancreas surgeon, working out of Queen Elizabeth Hospital in Birmingham, who, as you may know, is the founder of the Paranoia Registry and will discuss with us the latest insights from that. So, without further ado, I shall introduce Professor Schrem. Thank you.
Ladies and gentlemen, I will talk about how we reduce the complications and also mortality after pancreatectomy. This is my disclaimer. So in Chemnitz in Germany, we found that 30-day mortality after pancreatoduodenectomy was too high, and therefore we decided to go through a demake cycle to improve outcome. When we looked at the data, we found that even after previous efforts to improve 30-day mortality, it was still above 7%. So we analyzed what was going on. We analyzed all postoperative cases with 30-day mortality from 2023 and 2024. And from this, we deducted an Ishikawa diagram. This diagram was also informed by published literature to identify potential root causes for too high 30-day mortality. And from this, we derived improvement measures. This is the original Ishikawa diagram that we came up with. It's in German language, so I hope you excuse this. I will shortly summarize. I won't go into every detail. So this diagram identifies potential root causes for elevated 30-day mortality related to the operation itself, to the surgeon or surgical competence, to perioperative management, to machine-associated factors, like, for example, the absence of a management dashboard or the absence of an internal database. The Umfeld, this is in German means the surrounding conditions. This includes the population that we serve with pancreatic surgery in our region. This includes local epidemiology of comorbidity, things like that, and also diagnostics and the availability of interventional radiology 24/7. So initially we focused on those factors that we can have most control of, and the first step was to employ 3 new surgeons with extensive experience in pancreatic surgery, and then the next step was to limit the number of surgeons to perform this kind of surgery to only 3 surgeons, with the goal to achieve a minimum of 30 pancreatoduodenectomies per surgeon per year in order to improve 30-day mortality. And moreover, we also reorganized preoperative and postoperative care structures. We improved our tumor board, for example. We looked more carefully for indications with more extensive workup and treatment of comorbidities and things like that. Furthermore, we also decided to analyze our internal data regularly so that we have an updated internal database and a management dashboard to manage our pancreatic surgery more tightly. And we developed new internal SOPs to improve outcome. Furthermore, we decided to intensify internal and external audits of our pancreas cancer center. And the initial results are very promising. So if we look at the first 6 months, sorry, the number is wrong, it's 2025. In the first, 24, sorry. In the first 6 months of last year, we had a 30-day mortality rate of 7.5%, which is clearly too high. And after 4 months, after introducing our measures, we could reduce it to 0%. This number has to be looked at with caution because it's only a small number of cases, 32 cases. In order to stabilize and consolidate this improvement, we need further strategic moves, of course. We are fully aware that we need to reduce, for example, our Prof B and C rate, and we also need to improve our team to make it more coherent. And in order to do that, we decided to bring our data into the paranoia registry, which will be introduced by Keith Roberts in just a few minutes. And we also asked Professor Keith Roberts whether he would accept that he is our mentor for our pancreas cancer center in order to improve 30-day mortality. So the DMAIC cycle keeps on spinning. The next goal would be to reduce POP B and C rates measurably with the help of the paranoia registry and with a mentorship. And by this, we hope to consolidate low 30-day mortality rates. The evidence for interventions to reduce POP B and C rates is very low because most randomized trials, or all randomized trials that we are aware of, are statistically underpowered. So this is a real challenge. So in order to test, for example, whether a device like HemoPatch RT, that is deployed on this picture, is able to reduce the POP B or C rate, we would need evidence from real-world data. And how could we achieve that? In order to test such devices, whether they could help us to improve morbidity and mortality, we would need, in our opinion, a multi-center observational registry trial. And such a trial could be done, I think, best with the paranoia registry. These are some proposed study objectives. They require a more coherent debate with more brains in the game. Whether these are the correct or the best possible primary and secondary study endpoints needs to be discussed. But I think the paranoia registry is a very powerful tool to make such a study a powerful reality with much enhanced evidence of whether such a device like HemoPatch or other devices are actually helpful to reduce POP B and C rates. Why this is the case, why I'm so convinced of the paranoia registry, will be obvious after Keith's presentation. There's a risk information in there for HemoPatch, just to make you aware. You can also access this presentation as well as Keith's presentation with the barcode. And by the way, you can also access the paranoia registry via the barcode and get your data into the registry. Then you can benchmark your own results in regard to POP B and C, but Keith will explain this. This slide is from our hometown, Chemnitz, and we extend our warm-hearted greetings to all of you from Chemnitz. This is the cultural capital of Europe this year. Thank you very much.
Thank you very much, Professor Schrem. Very interesting. I'll hand over now to Professor Roberts. We'll take questions at the end. Thank you.
Great. Thank you, Catherine. So thank you to Baxter and the team for supporting this, and thank you very much to the warm welcome from Harald. And so it's a pleasure and a privilege to be here. So Paranoia, what is it and why might we need it? Here are my disclosures. So it's very clear that for an elective surgical procedure, the mortality after Whipples is really very high when you compare it to other elective operations. And you can see from UK data, over a 15-year period and 15,000 Whipples, the mortality rate at 90 days was 6.5%. And from international registries, it's very clear that in-hospital mortality is a problem, and pancreas fistula is a problem. And from Chuck Bolmer's very nice paper, it's quite clear that the predominant cause of death for most patients after Whipple is pancreas fistula. So how do we reduce pancreas fistula? Well, obviously what you do is you do randomized trials of interventions to do this. And so Harald just showed you a summary of the paper. And there are lots of randomized trials. So we looked at 55 trials, 7,500 patients, and 22 different interventions, but most trials were negative. So why is it? Well, it's predominantly an issue of power. A Whipple is not a common event, but you need common events if you're going to do a randomized trial. And if you look at the median study size of randomized trials, it's 110 patients, so 55 patients in each arm. And if you think of clinically relevant fistula, the event rate is 10–15%. So you're looking at a handful of events in each arm in your randomized trial. And what you see on the figure on the right, in the black diamonds is the actual sample size, and then based upon the fistula rate in each trial, you then do a power calculation to see a 25, 50 or 70% reduction in fistula. And the point is, the trials are underpowered. So how do we arrive at this situation? Well, the problem is we're surgeons. We're quite optimistic creatures, right? So if you look at the estimated incidence of fistula in the randomized trials when they design them, they overestimate the incidence by 70%. And we have quite hopeful assumptions of how effective the interventions will be, and we assume there'll be a big reduction in pancreas fistula. But actually what you see is the actual event rate is not that common, and the potential benefit of the intervention may not be quite as good as what you thought. And so you end up with an underpowered trial. And you know the problem. It takes years to conceive a trial, to get the money, it takes years to accrue the patients, and the cycle for a lot of randomized trials in surgery can be 10 years from conception to delivery of the data. So we need level 1 evidence. It's very clear. We definitely need level 1 evidence. I'm not saying we're not going to do it. But there is another way to accumulate data, and it's real-world registry data. And it's a way to empower the surgical community to put their experience into a registry and then present that data back to the community. And so we established the Paranoia Registry a couple of years ago, and we use a couple of novel techniques which I'll go through in the registry. The registry only collects data pertinent to pancreas fistula. It's not a huge data set to report every outcome known in pancreas surgery. It purely collects the data so that we can do risk adjustment. It collects, when you register, you describe your surgical technique, PG, PJ, 2-layer, 1-layer, interrupted, and so on. And then you don't need to put that data in again unless you change your technique. And for every patient, all you really need, age, gender, estimated blood loss if you want to use the original FRS, duct width, BMI, was it hard or soft, if the patient had neoadjuvant therapy and the pathology. And then you can calculate using common fistula risk scores. So what are the benefits? Well, first of all, risk adjustment of patient factors. You all know that 2 patients' risk of pancreas fistula can be wildly different. Why is this important? Well, if you take 2 surgeons in 1 unit and look at their fistula rates, and this is real data, then you see that one surgeon has a higher fistula rate than another. Now, if you're the head of the department or you're one of these 2 surgeons, how do you know where you are? Is one person doing bad? Is one person doing good? What you need is risk adjustment. And with a QSUM, you do risk adjustment. And if your outcomes are as expected, you'll go along the horizontal line at 0. And what you see here is this surgeon here had evidence of a learning curve in green, and actually by the time they've done 30, 33, 34 Whipples, they have one less fistula than expected, so they're doing fine. The outlier is the experienced surgeon. So we did just this in Birmingham. So my colleagues, and we published this, I don't know, 8 years ago now. And what we saw was the experienced surgeons had a much lower fistula rate, 10% versus the new surgeons, 25%. And this is hundreds of cases. And these are the QSUMs for the 3 experienced surgeons. And you can see characteristics of true experts. It's just a steady reduction of fistula. And by the time you get to the end of these, you see a significant reduction in observed numbers of fistulas compared to expected. These are the QSUMs for the 5 new consultant surgeons, and a much more heterogeneous pattern of the QSUM. A couple of surgeons had an excess, one surgeon had a reduction, and a couple of surgeons doing as expected. So what about the registry? Because we're here to talk about the registry. So I've just picked out a few examples of centres. So I've grouped surgeons by centres for this figure. And if your centre is above the line, you have more fistula than expected. If you're below, you have less than expected. And then if you look at the individual surgeons from those centres, you can see that there is variation from surgeon to surgeon, which is what you'd expect based upon those QSUMs. And it's normal to have different outcomes. And then if you plot the QSUMs for those particular surgeons, you can see really quite different fistula rates when you risk adjust. What you also see is learning curve. So the red line is the first 50 Whipples averaged for newly appointed surgeons. The next 50 Whipples is the orange line, so 50 to 100. And then from 100 to 150, you see a further reduction in fistula. So experience is really important. We know this, but has anybody ever really shown that before? So what's the other benefit of the registry? Well, it's risk adjustment of the surgeon effect, and going back to the challenge of helping prove the level 1 evidence. So we know there is a randomized trial that shows a fantastic reduction in pancreas fistula with hemopatch. And it's a really nice trial, and it's done very well if you look at randomized trial methodology. And it's good clinical practice as surgeons to adopt level 1 evidence into your own clinical practice. But what's better clinical practice is then to share your experience of the real world into a registry, because you can take those 72 patients in the trial, and if you do 10, 20 Whipples a year, and you have 100 surgeons putting data in, you can accrue a huge number of patients. But how do you adjust for that surgeon variation that I just showed you? These are real examples. So 2 registry surgeons do different surgical techniques, and they have different fistula rates. A new treatment comes along for fistula, magic pill. So magic pill has been told to you it's the solution for pancreas fistula. You'll never have one again. And so what do you do? So these surgeons have both adopted magic pills into their routine practice, and they've got cases into the registry. Well, what you do is you take from their prior experience patients entered into the registry, and they act as controls for each surgeon. So each surgeon has their non-intervention controls from patients they've already put into the registry. And then this is real data. You can then start to look at the QSUM for control and intervention with the surgeon effect largely taken out. And this, again, is real-world data. So these are 3 different interventions. I haven't named them, but these are 3 different interventions postulated to reduce pancreas fistula from level 1 evidence. And what you can see, after 122 Whipples, 62 Whipples, and 42 Whipples, there's no apparent difference. But that probably goes back to the original challenge of power. Registry data could really overcome some of the issues of power. So going forward, it's growing the network, and there will be people who are very happy with their technique, there'll be people who don't believe in it, but there will be a lot of surgeons who would like to engage and would like to know more. And I think there's a cycle here. You identify the new emerging level 1 evidence, and you present it to the network. Then the network surgeons say, I like the sound of intervention 1, intervention 2, I don't like the sound of that. And you get feedback as to which interventions surgeons may incorporate into their practice. You update the registry to capture those data, and then you present the data back next year, and you repeat your evidence synthesis and see what new interventions are on the horizon. So that is how, or the benefits of the Paranoia Registry. Please consider joining. There are 232 registered users from 56 countries. Due to the limitations of time, I can't go through registry data, but we've just hit 1,000 patients in the registry, and there's a lot of variation. Even before you look at outcome, there's a huge variation in what people do. And so we're going to go from paranoia to prosper. Paranoia, maybe a little bit of a negative connotation. So we're going to evolve to prosper, and we would like our colleagues to prosper in their careers and their outcomes, and we're going to evolve to the Pancreas Registry of outcomes and strategies for fistula prevention after resection. And there should be, it might pop up. There may be a QR code if you wanted to link. So thank you very much.
I'll just ask a sort of practical approach. So if somebody here from the room or someone listening online wanted to start inputting data tomorrow, what do they have to do?
Well, you worked out already that I'm not very good with tech, because there was supposed to be a QR code appear on there. But if you Google paranoia, you'll find a link, or I think you said it was on the
Where the QR codes
QR code
here in the room and for the online audience will take you to the presentations, and we have the Paranoia access in there.
Yeah, and so once a surgeon has enough cases in the registry, you'll be able to pull out your own QSUM, and you'll be able to look at other data in the registry. It's completely anonymized, so you don't know who anybody is, and each user obviously has a completely anonymized username. And in time, if you want to look at fistula rates for PG, PJ, or if you want to benchmark yourself against somebody who's done a similar number of career Whipples to yourself, you'll be able to do that. We don't currently have the functionality because the volume isn't there, but it's very easy to do that, and that will come. They're the goals for the next 12 months.
Brilliant. And Professor Schrem, as someone who's tried to get this going in their department, any tips on practically how to do it, or challenges you faced getting it going in your department?
I worked in different hospital environments in Germany and Austria, and now in Chemnitz in Germany. And the typical experience is when you bring up the Paranoia Registry that some colleagues feel reluctant to type their data in because it brings you a very brutally honest feedback on where you actually stand. So my experience is when you have a pressure point, like for example, what I demonstrated, a high 30-day mortality rate, where you need to come into action to improve that. You end up in thinking maybe we should go a data-driven approach, and a data-driven approach to reduce the POP B and C rate that is rational and objective would be the Paranoia Registry, the QSUM curves, because then you know exactly where you stand. And in my experience, if you start turning your attention and awareness to this, your results already start to improve because you focus on this now more. And but the reluctance to type in personal data that you actually produced with your own patients that you operated upon is there. It's a cultural shift that is required, and you need to be very careful with this data. So in our center, we would limit the accessibility to internal discussions of the QSUMs of our surgeons to only those people who are doing these kind of surgeries, and not any other surgeons or any other people. So in order to have a strong team that supports each other and where we share data that is, in our view, also to be viewed sensibly.
Okay.
So I think this is a major aspect that I learned.
Yeah. Should we go to a question in the room?
Thank you.
Could we have the lights up in the room, please?
Derek Manus from Newcastle. So Keith, two questions. One is, I presume the database is prospective. I mean, so every case is being put in, otherwise you're going to miss quite a lot of cases.
It is better done prospective. The data points are very hard data points. So if you record gland texture in your operation note and duct width, actually retrospective is fine.
But you could decide not to put it in the database because things really went wrong. So
Yeah, that's right, and this is one of the challenges of registry.
I mean, so the other thing is about CUSUM. So as you know, I use CUSUM a lot, and if you want CUSUM to work, you have to make it prospective because otherwise you're not going to be able to monitor surgical outcome. And you've shown sequential CUSUM, but you haven't shown the tabular CUSUM, which is where you adjust the baseline. So if a surgeon is doing badly and he's had a run of leaks, you have to do a certain number of cases safely to get back to the baseline and start again. So just doing sequential, you'll miss the guys that are actually going under the radar, just to mention.
Yeah, no, thank you, Derek. I mean, you're absolutely right, and one of the functionalities of this is if you change your technique, the CUSUM will reset to 0, and you'll be able to compare your CUSUM with your 2 different techniques. So yeah, that functionality is built in, and I have got the slides. I just, in the interest of time, I didn't have that. But most surgeons don't change that technique. It's interesting.
Thank you. We have another question from the room.
Thank you. I'm Jasmine Smits. I'm from Utrecht, the Netherlands, and I have a question for both of you. So, Professor Schrem, I was wondering if you have considered of doing something about their post-operative care, and maybe if you considered using something like the Porsche algorithm. I don't know if you are familiar with it, but we just heard about it in the previous session. So that's my question for you. And for Professor Roberts, if the Porsche algorithm is incorporated in the platform, if you can, maybe we can use the platform to evaluate if the algorithm is as useful as the trial shows in actual practice.
So to answer your question quite openly, we didn't introduce the Porsche algorithm in our initial actions that we took to improve quality, but our journey is not finished. So we started with obvious things, like, for example, reducing the number of surgeons to perform this kind of operation, so that each surgeon can have enough cases per year to have a sufficient experience and also a learning experience, especially when we monitor the performance with CUSUM curves. This is important, I think. And we did basic stuff, but along the line, we would have to look at many other aspects. I fully agree with that. As you could see in the Ishikawa diagram, there are many fields that we did not address yet. So we focused on the simplest and most obvious things to do. But we are on a journey that we just started. So we are not there where you would expect us to be. Sorry for that.
Thanks, Jasmine. You're absolutely right. I mean, you could evaluate the real-world impact of Porsche through this platform. And there are lots of innovations and interventions that can be evaluated. And I think the strength of the registry goes to what Mark was saying. It's about collaboration. And I think, as I said, the network will be asked, what interventions would you like to use? And then the top 5 get prioritized and put into the registry for the current year. I think if you try and put everything in, you'll suffer the same issue with power. So ask the community what they think is the important strategy, evaluate it, and then put the feedback. And I like Porsche very much. All this work on randomized trials and interventions, Porsche takes a very pragmatic view. Maybe you can't reduce fistula, but you can reduce the harm of fistula. And it's, yeah.
Thank you. I have a couple of questions online regarding sort of specifics of then how data is unified to compare it. So for things like where there's a modified technique, even something like a Blumgart PJ anastomosis, how can you be sure that that is being unified and compared properly where techniques may still be slightly different?
Yeah, so I mean, a registry will fall down on some of the interrogation. So if you run a randomized trial of surgical technique, people take photographs, there's standardization of the technique, and you have to show that you can meet a certain standard. But that's not real world. So the real world is that we all have different outcomes. And why is it? It's more nuanced than PG versus PJ, or what my thing looks like at the end of the operation. So, yeah, those things are potentially weaknesses, and you have to trust people when they say they're doing what they do. But
And have any of the data and the insights yet informed your practice in choice of technique or anything else?
Yes, I won't give the game away yet.
Okay.
But yes. Yeah, I think the bigger thing here is, why do some surgeons have apparently lower fistula rates? And my observation is, from the surgeons I know, you can kind of see it. You can see an operation when it's going well, and some surgeons' operations tend to go well more often than others, and that's not coincidence. And there is something fine about that, and it's very difficult to measure. How can you quantify that? But it's very clear, experience counts. So there's something that you acquire with finesse. When you do the same technique on paper for your 150 Whipples, except the last 50, you have a lower fistula rate than your first 50. But on paper, it's the same technique. The only thing that's changed is your experience. And it's very difficult to measure.
Interesting. Any questions in the room? Okay, I still have some online here. So we have a couple of questions around Hemopatch, around the actual application of where it's applied during Whipples, and someone here is asking as well if it should be secured with sutures.
The photo that I showed was the first experience we gathered 3 weeks ago or 4 weeks ago. And this was the Hemopatch RT that we used. I have used the Hemopatch without RT before, and applying it was very easy. It stitches to the tissue very easily. What you need is patience, because the surgeon has to wait 2 minutes to let it react with the surrounding tissues, and 2 minutes can be long for surgeons. But after you waited this 2 minutes and looked at the watch with the appropriate time waiting, it stitches so well that you don't need to suture it at all.
Okay, so it's sticking really well, but
yes.
not needing suturing.
No.
Any input from you?
No, I mean, it's logical. You know on day one if your patient is at risk of fistula, because the amylase is in the drain, and you stitch the soft pancreas, you can see the liquid coming out from the sutures. So it makes logical sense to put a barrier there.
Okay.
There's one important aspect we discussed about it yesterday. How could a device like Hemopatch prevent a fistula if the pancreatic enzymes destroy everything? How could this possibly be? We were discussing this today as well. And I think the probable correct answer would be that with this product, it's a synthetic chemical attached to collagen that prevents the destruction of the whole product by amylase and lipase and other enzymes. But in order to understand it better, it would be interesting to learn more about it. I think that's obvious. And in order to know whether we should use it on a routine basis, we would need more evidence, and real-world evidence would be ideal. Therefore, I think to investigate this in an observational registry trial using the paranoia registry would be great. That's what I think.
And are you using it as part of a standard practice, as selecting patients who you think are higher risk, or rarely?
One would have to devise a protocol for an observational registry trial in order to distribute patients with versus without Hemopatch, for example, or any other device, and make a committee decision on what to prioritize in the registry, and then it could be investigated thoroughly, I think.
Yeah, I mean, there are randomized trials through registries. So I think if your intervention has already been evaluated in a randomized trial, then just observe the real-world practice. And that's feasible now. You can run randomized trials through registries.
Okay, thank you. Any further questions in the room? Yeah, we have one here.
Hi. Bloom-Gotten anastomosis is quite bulky. you don't have a flat surface between the bowel and the pancreas. How does it sit, the hemopatch, with that?
I never tried it out with Bloom-Guard anastomosis. We don't do Bloom-Guard anastomosis, but with experience with the device, I would say you put it on the anastomosis, and with a cloth, you put pressure on it with your hand, and just wait. And it will mold into the connection easily. The only thing you should take care of, you need a very dry operative field. This is very important, especially for hemopatch RT. You have a dry operative field, you apply the patch and some soft pressure and no movement for 2 minutes. And this takes your patience. That's the biggest challenge. And then you see a very nicely molded device. It's very easy.
It's extremely flexible and moldable. It has to be applied sort of the correct site the first time. And whilst you don't want to apply it into a pool of blood or liquid, because that would sort of activate the pegs in advance of its contact with the tissue. You can use sodium bicarbonate as well. So many of our surgeons use sodium bicarbonate to attach it to a very dry area, which helps moisten the patch, helps it form the bonds with the tissue, and its very flexible nature helps to sort of wrap it around the area to apply it.
But you can also leave the sodium bicarbonate away. It works as well.
Thank you.
Yes?
Thank you very much. Just I want to ask, do you have experience with giving sandostatin injection after the operation? Because actually we are using that, and the technique is the same technique, but the leakage will be less with sandostatin injection. And if you use it, is there any side effects like cholestasis or something like that from the sandostatin?
Oh. We have used sandostatin previously, not in Chemnitz, but in other institutions where I worked before. And I didn't see an effect but that was very convincing for me. I think the evidence in the literature is also not that clear. So currently we don't use it. Do you use it?
So, well, the registry captures lots of different things that you might do to your anastomosis. So it captures your anastomotic technique, but it also captures any adjuncts that you may give, whether they're pharmacological, whether they're stents, whether they're patches, whether they're mental wraps. So all those individual things that some surgeons do and some surgeons don't are captured in the registry.
So this could be investigated on an evidence-based level with the registry too.
Okay, why not?
We have a couple of questions here online about the texture of the gland. So, would you be more inclined to use a hemopatch or another kind of preventative device if you have a soft gland as opposed to a hard pancreas, or does any thoughts on that?
My thoughts are that you should probably do the same thing every time.
Mm-hmm.
Okay.
I would say I would want to know the evidence of what's the benefit of using it. Mm-hmm. And if you analyze the data, I would be curious to see how big is the influence of the softness of the pancreas versus intervention, yes or no. This should be analyzed on an evidence-based basis. But I agree with Keith that you should do the operation always the same.
Okay, thank you. And what about your opinions about using an mental patch for the PJ anastomosis?
I mean, the data is mildly supportive.
Okay.
It makes logical sense. You're putting a barrier between your anastomosis and the thing that causes you most harm, you know, the GDA stump.
Okay.
I agree with Keith, but I think, again, the power of evidence is not that big. So it's like with many things in pancreatic surgery, we would really love to have more evidence, to be more scientific in our approach. My feeling is that in the safety of performing pancreatic surgery, awareness is a very important factor. And I think people who actually do something or are very aware of the anastomosis and try to improve their outcomes will have better outcomes, because when you direct your attention to this and your awareness, you will be more sensible about everything you do. And this is an effect that should be also taken into account. When we started to improve 30-day mortality, when we agreed upon our intention to do this and to go methodological about it by doing simple stuff like looking at all the patients that actually died within 30 days, analyze the whole cases and everything, standard stuff. By deciding this, already the results improved. So I think awareness is very important, plus robust data.
Yeah, and this robust data is going to come from inputs into the Paranoia or Prosper registry, isn't it?
So yeah, so I mean, I think the Dutch have a randomized trial coming on aiming to reduce pancreas fistula, and I think an ammental wrap is one of the interventions. I think the trial will be a bundle of interventions, so that's one of the interventions in that trial.
Okay, thank you. If we don't have any more questions in the room, then it just leaves me to thank everyone here for joining us today. Thank you for those online who have been listening to us from all around the world. We had a lot of people listening online. And of course, thank you to our two speakers. It's been really interesting, and our pleasure to have you speak to us today. So thank you, Professor Roberts.
Thank you,
Professor
Catherine.
Schrem.
Thank you very much. Yes. Thanks, Harald. Great. Thanks, Catherine. Thank you very much.
Thank you.